It's time to start. Please take your seats. Good morning, everybody. My name is Basel Molaeb. I work in Saudi Arabia. I'm a manager of infection prevention department in Al Musa Specialist Hospital. And it's an honor for me to be the co-chair of this session with my colleague Shahid. And I'll be introducing the first speaker for this session. Please have your seats and make sure kindly to turn off your mobiles or to silent mode just to prevent any interruption. On behalf of my co-chair, I would like to welcome you all to this session. In room 2, the session title is What is Minimum and Cost Effective for IPC in Settings with Limited Resources? This session, the first speaker in it will be Dr. Jost Hopman, consultant microbiologist, medical director, Radboud University Medical Center, and the Netherlands strategic IPC lead for MSF, and he's a consultant for Netherlands National Institute for Public Health and the Environment, and a consultant for WHO. He will have a talk about the minimum standards for IPC in settings with limited resources. Welcome to stage, Dr. Jost.
Good morning, everybody. It's a real pleasure to present here on the minimum requirements by WHO. I was asked to fill up the gap because actually Ben Park from CDC would have presented today. I don't have any conflict of interest to declare besides the fact that I'm a consultant for several international organizations, Médecins Sans Frontières, WHO this year for the systematic review on this piece of work for minimum requirements, and the National Institute of Public Health in my own country. Start off with the acknowledgements because this, the work that I will present is a huge piece of work by a very large group. First and foremost, the Global IPC Unit in Geneva, Anthony, Alexandro, Paul, Julie, and Benedetta. And then other stakeholders as well, like the African CDC, the US CDC, the WHO Regional Office in Africa, and the Eastern Mediterranean Office. And then lastly, we had a large meeting in Ethiopia in April with a large group of participants. Some of them are here in this room. And we came up with these final conclusions on minimum requirements. So to start off, obviously everybody knows in this room, we have the IPC core components already. They were issued in 2016. And the guideline contains 6 national and 8 facility-based core components. The guideline uptake is essential to improve the quality of health service delivery and patient outcome, and particularly in low and middle-income countries. If you put it in a nice graph, it looks like this. So you've got your IPC program, and then in the middle, all the enablers. Or actually the guideline, the education and training, and then you've got the enabling environment. And everything is surrounded by a multimodal strategies for implementation. However, this all sounds really nice, but for everybody that has been working in low and middle income countries and in resource poor settings, it is really difficult to implement. So implementation of IPC programs poses large challenges, both for national health governments and for local health authorities. There's a huge, major implementation burden because of other competing health priorities and often very limited available resources. So what has been advised is to come up with a stepwise approach to do an assessment of the local contextual situation and to make a prioritization. The ultimate goal, obviously, is to achieve an implementation and improvement of all core components, as they are all deemed essential by the group of experts in 2016. So my question to you is, why do we need additional minimum requirements? Well, the answer is that especially for countries where IPC is limited or even does not exist, it is critical to start this journey by ensuring that at least minimum requirements for IPC are in place. When I was, prior to this meeting in Ethiopia, I was teaching in South Africa, and I had students from South Africa, Zim, and Botswana, and one IPC nurse from Italy, from Médecins Sans Frontières. And I actually asked them this question: so what for you are these minimum standards? And they came up with this very nice overview that for them, and these are people that are really working in rural hospitals in Africa with very limited resources, for them critical IPC activities is: one is hand hygiene, two, cleaning and disinfection and sterilization, three, isolation and triage, four, surveillance, and five, occupational health, and especially post-exposure prophylaxis and vaccination, which in their context is extremely important. And for them, critical enablers is really all about the resources and the management and the leadership. And everybody that has been working in those settings knows that without this backup of your hospital leadership, really nothing is going to work. So what is the journey? So the journey is that we have minimum requirements. Through a stepwise approach, we finally reach the ultimate goal of implementation of all the core components. And obviously, all these actions have to be linked with many other actions that are out there by WHO and others to prevent that there's any parallel and kind of actions. So if you ask yourself the question, what are the minimum standards for effective IPC programs aimed at reducing hospital-acquired infections? We had to do an exercise again, so we did a systematic review of the literature prior to this meeting in Ethiopia, and we reviewed, Anthony did, reviewed all existing guidelines out there in all countries, and we were asking ourselves the question, are they stating explicitly about minimum requirements in IPC? So we used a search strategy. If you want to go into more detail, there's a poster after this session, so I will go through them a little bit fast. We reviewed 7,800 articles, and then we chose a strategy where we actually categorized the IPC interventions in horizontal interventions and vertical interventions. And the vertical interventions are then specifically targeting specific hospital-acquired infections or specific microorganisms. And the horizontal interventions, on the other hand, are covering all kinds of microorganisms and all kinds of hospital-acquired infections. So this is what the screening process looked like. So we started with over 7,000 articles and ended up with 47. And the results were that the quality of the included articles, the quality of the studies was low, mainly reviews and systematic reviews and before-after studies. Most of them are from high-income countries, and a high percentage of these systematic reviews were on MRSA and C. diff from high-income countries, mostly the US. And they were mostly facility-based. So if you put them in a graph, first of all, I will show you the horizontal interventions that were stated as being minimum. Hand hygiene was on top, and then the isolation, and you can go through the list downwards. Vertical programs were mentioned really in a lower frequency than the horizontal interventions being minimum requirements. I think this is a very important finding. And then catheter-related bloodstream infections were stated as being most often being the minimum requirement. So our conclusion from the systematic review is that horizontal interventions are mentioned much more frequently than vertical interventions as being minimum or critical or essential. And then most frequently mentioned IPC measures are hand hygiene, transmission-based precautions, surveillance, education and training, the built environment, guidelines, and then monitoring, audit, and feedback. So I already mentioned this meeting in others, so this is the group of people that participated. And the whole idea is, as I stated, that we really go through this journey. So in low and middle income countries without any access to IPC programs, you really start with the minimum and then you go up to these core components. My slides that I will now present is the final conclusions from this meeting for every core component that is already stated and issued by WHO. So I will go through them, and I decided together with the chairs of today that I will go through them a little bit fast. They will be available for you afterwards, because we really want to have discussion with you about the necessity of minimum requirements and what you think we should do with them. So CC1, we divided the minimum requirements really in national, primary care, secondary care, and tertiary care. So I will just highlight a little bit the most important findings. So on a national level, the minimum requirement is that we deem that there should be one full-time focal point trained in IPC, and that there should be a dedicated budget. On primary care, we said there should be a trained IPC link person and one IPC trained healthcare officer. Secondary care and tertiary care, we stated that there should really be an IPC focal point. And what we mean with this is that it should be a trained IPC officer, a nurse or a doctor, per 250 beds, with a dedicated budget. And then lastly, in the tertiary care system, tertiary care hospital, we added as well that there should be an IPC program, a multidisciplinary committee or team, and access to a microbiological lab. And we can seriously, sorry?
Just excuse me, everybody, as addressed by the organizing committee, and since this is an unpublished data yet, so they asked not to take pictures for those slides, please. Thank you. And no tweets and social media shares. Thank you.
Thank you. Core component 2, on a national level. It was deemed that the minimum requirement would be that there should be evidence-based, ministry-approved guidelines that are adapted, and this is very important, to the local context and reviewed at least every 5 years. Primary care, there should be evidence-based, facility-adapted SOPs based on the national guidelines, and at a minimum, and this is something we discussed in great length, there should be SOPs for hand hygiene, decontamination of medical devices and patient care equipment, environmental cleaning, waste management, injection safety, healthcare protection, aseptic techniques, triage, and the basic principles of transmission-based precautions. And there should be routine monitoring of the implementation of at least some of these SOPs. Secondary and tertiary care, all requirements as for the primary care, obviously, with an additional SOPs on transmission-based precautions, aseptic technique for invasive procedures, and specific SOPs to prevent the most prevalent healthcare-associated infections based on the local context. Core component 3. On a national level, it was stated that we need national policy that all healthcare workers are trained in IPC. An approved IPC national curriculum aligned with the national guidelines and endorsed by the appropriate body. And a national system and schedule for monitoring and evaluation to check on the effectiveness of IPC training and education. And this should be done at least annually. Primary care. All frontline workers, clinical staff and cleaners must receive education and training on the facility IPC guidelines and SOPs upon employment. All IPC link professionals in primary care facilities and IPC staff at the district level need to receive specific training. On the secondary care level, all frontline clinical staff and cleaners must receive education and training on their SOPs upon employment, as in primary care, and all IPC staff need to receive specific training for their job. Tertiary care, all frontline workers and clinical staff must receive education upon employment and annually, and this is in addition to secondary care, and all IPC staff need to receive specific IPC training for their job. Surveillance. On a national level, the establishment by the National IPC Focal Point of a technical group for hospital-acquired infection surveillance and IPC monitoring, which should be, and this was clearly stated, multidisciplinary and that develops a national strategic plan for hospital-acquired infection surveillance with a focus on the priority infections based on this local context. On the primary care level, the hospital-acquired infection surveillance is not required. I think this is something for the discussion as well. Secondary care hospitals, hospital-acquired infection surveillance should follow national and subnational plans, and on the tertiary care level, active hospital-acquired surveillance should be conducted and include information on AMR. Enabling structures and supporting resources, and the method of surveillance should be directed by these priorities and plans of the facility. And there should be a timely and regular feedback that is needed to provide to key stakeholders. Then, I think one of the most important core components, core component 5, multimodal strategies. So, on a national level, there should be use of multimodal strategies to implement IPC interventions under the coordination of this national IPC team. The primary care level, the use of multimodal strategies at the very least to implement interventions to improve hand hygiene, safe injection practices, decontamination of medical instruments and devices, and environmental cleaning. On the secondary care level, the use of multimodal strategies at the very least to implement interventions to improve standard and transmission-based precautions, so we're really broadening up. And in the tertiary care hospitals, the use of multimodal strategies for standard and transmission-based precautions and triage, and those targeted at the reduction of specific infections in high-risk areas and patient groups. How am I doing on time? 1 minute? Okay, we'll skip these. And go to the built environment. The built environment, I think, is a very important one as well, so I really want to use that last minute. We had a lot of discussion on the built environment. I think it's a very difficult one to come up with minimum requirements. So on the primary care, we decided that water should always be available on the premises of basic IPC measures, including hand hygiene, cleaning, laundry, and decontamination of medical devices. There should be a functional hand hygiene facilities always available at points of care and in the toilets. There is a minimum of 2 functional improved sanitation facilities available on site, 1 for patients and 1 for staff. The facility layout should allow adequate natural ventilation, decontamination of reusable medical devices, triage and space for temporary cohorting of isolation if necessary. Sufficient and appropriate IPC supplies and equipment should be available. Power should be available, and sufficient and appropriate labeled bins to allow waste segregation and waste is treated and disposed safely. Then for secondary and tertiary care, we said safe and sufficient quantity of water is available for all IPC measures and specific medical activities piped inside the facility at all times. Functional hand hygiene facilities are always available at points of care, toilets and surface areas. And in tertiary care, we stated that at least, as well, that at least 2 functional improved sanitation facilities should be available to contain waste available for staff and outpatients, and 1 per 20 beds for inpatient wards. The facility should be designed to allow adequate ventilation, natural or mechanical as needed, to prevent transmission of pathogens. The facility should have a dedicated space area for performing decontamination, a decontamination unit, according to guidelines and SOPs. The facility should have adequate isolation rooms, or at least 1 room for cohorting patients with similar pathogens if the number of isolation rooms is insufficient. Sufficient and appropriate labeled bins to allow waste segregation again, and sufficient and appropriate supplies and equipment and reliable power electricity are available for performing all IPC measures, including standard and transmission-based precautions. So in a very rapid space, I hoped I gave you some insights in the minimum requirements that will be issued hopefully in the coming months, and I leave it with this. Thank you.
Thank you, Dr. Jost, for this overview. I leave the stage now for my co-chair, Shady, to introduce our next speaker. Questions will be at the end of those sessions, please. Yes, please. Okay. Yeah, we'll consider that.
So, for your request. Core component 6, on a national level, the establishment of a national IPC focal point or a technical group for hospital-acquired infection surveillance and IPC monitoring, which is multidisciplinary, develops a national strategic plan and an integrated system for the collection and analysis of data, provides training at the facility level to collect and analyze these data, and develops recommendations for minimum indicators, for example, hand hygiene. Primary care level monitoring of IPC structural and process indicators should be put in place at primary care level based on the IPC priorities identified in the other components and in the local context. And this is requires decisions at the national level and implementation support at the subnational level. Secondary care hospitals, a person responsible for the conduct of periodic or continuous monitoring of selected indicators for processes and structure, informed by the priorities of the facility or the country. Hand hygiene is regarded as an essential indicator to be monitored. Timely and regular feedback needs to be provided to key stakeholders in order to lead to appropriate action, particularly to the hospital administration. Data should always be provided to the national level in alignment with any national coordination of policies, and national levels should provide timely feedback to facilities and provide interpretation of data or guidance for improvement and actions. Then core component 7, on the primary care level, to reduce overcrowding, a system for patient flow, a triage system including referral system, and a system for the management of consultations according to the existing guidelines. To optimize staffing levels, assessment of appropriate staffing levels depending on the categories seen when using WHO and national tools, in line with national norms on patient to staff ratio and development of an appropriate plan. On secondary care and tertiary care hospital and levels, to standardize bed occupancy, a system to manage the use of space in the facility and to establish the standard bed capacity for this facility. Hospital administration enforcement of this system, a crucial one. No more than 1 patient per bed, spacing between beds of at least 1 meter. Overall occupancy not exceeding the design total bed capacity of the facility, and to reduce overcrowding and optimizing staffing levels, and the same minimum requirements as for the primary care. Thank you.
Thank you. We're a little bit over time, so if we can just adjust the second session.
Thank you. I'd like to introduce Dr. Alessandro C. Cassini, who's a surgeon and an epidemiologist. He worked previously for the European Center for Disease Control and is now with the World Health Organization in the IPC control unit. He'll be talking about the cost effectiveness of infection prevention and control. Dr. Cassini.
Oh, thank you very much. And thank you very much for giving me the opportunity to give a quick overview of what we know until now and what are our plans to improve the evidence around the cost effectiveness at IPC. And thank you, Jus, for presenting the minimum requirements, which will be one of, let's say, the kind of interventions that we want to test in terms of cost effectiveness. So I just declare I have no conflict of interest. I immediately start with a systematic review that was published in a technical report by ECDC in 2017, but actually the data is until up to 2012. There were 4, or let's say 3 groups of interventions that were assessed. One was hand hygiene, the other was PPE, and then there was the bundle screening, isolation, and decolonization that were assessed. And it was clear that hand hygiene was extremely not only cost effective, but but also cost saving. There were a couple of studies looking at hand hygiene enforcement within surgeons, but the baseline was already so high that it wasn't clearly cost effective. PPE was cost effective only in a number of the studies, whereas the group screening, isolation, decolonization was extremely cost effective and cost saving in most cases. However, depending on, let's say, the decolonization part was unclear, the effectiveness of the decolonization, and the universal screening did not seem extremely cost effective. Targeted screening was much more. The quality of the studies was poor or very poor, and that's the main limitation to these kind of studies. So the conclusion was that studies were heterogeneous, the evidence was weak, so it was extremely difficult to actually endorse any decision-making based on this kind of evidence. So that was unfortunate and a bit disappointing. So now that I'm at WHO, I think it's the moment and the opportunity to revive this, let's say, field of study a little bit more. So we started with a systematic review of the literature, where we have many more interventions that we are going to assess for. And we want to also stratify also by age, by geography, and by income level. Good news is that there are many more papers that were found. There's a lot that has been published in more recent years, and 154 papers were selected for full screen. So that's much more than the 28 that were selected before. And as you can see, these are the kind of interventions that we're looking at. There's also quite a lot of focus on the multimodal strategies. So hopefully we'll get some good evidence on that, and this should be done by the end of this year. So early next year we should be able to publish this. The outcomes that we're looking at are, a lot of them are focused also on costs, and there's a reason for that. ICER means incremental cost effectiveness ratio, which tells you if something is cost effective or not, depending on the threshold that one chooses. And the reason why we focus so much on cost is because the next step, and I'll show you a little bit more about that, is to work with OECD, with whom we've already worked in the past on other projects, to work with OECD to test, well, first of all, to create a model, and then to test these models in several countries. So we need to extract as much information as we can, not only on the effectiveness, but also on costs. So these ideas were stemming from a previous project that was the burden of AMR in OECD countries that resulted in 3 main publications. There are other publications as well. One was specifically looking a little bit more about the prevalence of HAIs, of healthcare-associated infections, in the EU countries. Another one was on the health burden of antimicrobial resistance, and OECD colleagues were looking at the health impact. But they did not only look at the health impact of antimicrobial resistance, but also on cost effectiveness of interventions, and that's what I want to show a little bit more. These are the kind of interventions that they tested, and obviously we're talking about AMR, so there are some interventions that are more specific and focusing on stewardship, for example, stewardship of antimicrobial consumption and prescription. But there were also 2 looking at hand hygiene and one on environmental hygiene. So I'm going to focus a little bit more on these 2 interventions. What was extremely interesting to find was that the OECD found that the hand hygiene, or improved and investing in improving hand hygiene, would be the intervention that would avoid the largest amount of deaths. And we're talking about OECD countries. The enhanced environmental hygiene also would be extremely effective in averting deaths. So not only deaths, but also in terms of the economic impact, the hand hygiene, the improved hand hygiene is cost saving. So you see those bars under the 0 mean that whatever the investment, you're actually saving, you're getting money back. And we're talking about direct costs only. So we did not even consider the indirect costs, meaning the cost of people that have to stay home because to care for someone who's infected, or other similar indirect costs. The environmental hygiene was cost effective, was not cost saving, but was cost effective, which is still an extremely interesting and important finding. So, and the probability of this cost-effective impact across the country is extremely high, especially looking at hand hygiene. So whoever, even in countries where there's less of an AMR problem, less of healthcare-associated infections, improved hand hygiene will still have a high probability to have an impact in terms of economic return on the investment. And there's a pretty good chance that environmental hygiene also will have that effect. So the conclusions, or some of the conclusions that I extracted from this report, which is extremely interesting, is that some policies require major investments, obviously, but a number of policies, such as hygiene interventions, both hand hygiene and environmental hygiene, can be effectively implemented in resource-constrained settings. And the first intervention would be to improve hygiene in healthcare facilities, including the promotion of hand hygiene and better hospital hygiene. These were just quotes from the report. And the economic impact figures that I was showing earlier also include the effect of these interventions on the overall risk of developing healthcare-associated infections. So they were, when it was hospital-based, the intervention, they were not only looking at the infections with antimicrobial resistant bacteria or microorganisms, but they were looking in general even at the susceptible ones. From another study, this is still unpublished, but from another study that is stemming from the European Point Prevalence Survey in hospitals, it's very interesting to see how there are IPC, let's say, indicators that in a way reflect IPC implementation that have a direct correlation with antimicrobial resistance and with infections in healthcare. So this is just to substantiate a little bit more the evidence around this correlation. Another thing that was found, and I'm sorry, the arrows they were placed correctly this morning. I don't know why it's not like that anymore. But another finding from the OECD report is that if you do groups of interventions, you're even more cost-effective or cost-saving. So, for example, one bundle of interventions that focuses in hospitals, like hand hygiene, stewardship programs, and enhanced environmental hygiene, has the effect of lowering the economic impact of 85%. And as you see, the blue bars below are much longer than the white bars, which means that in all countries, these kind of interventions are cost saving. So investing 1.5 euros per capita per year in the third package, which is a mix of interventions in community and the hospital, should avoid 27,000 deaths per year only in the EU countries. And the savings for example, the package 1, which is the hospital intervention, is of 3 euros per capita. So whatever you are investing, you should get 3 euros back per capita per year. And looking more specifically at the healthcare, at the hospital intervention, a little bit more specifically for each country, it's still interesting that just to keep in mind that we're looking only at direct costs. So for society in general, it should even have a higher return on investment. These are the opportunities. So looking at all OECD, it's not only 27, but it's now 47,000 deaths that can be averted through these interventions. And one of the countries that would benefit the most would be the US. Other conclusions is that healthcare-based policies obviously would result, as I'm showing, in a highest number of hospital days avoided, but the impact is very context-specific. For example, hand hygiene in Italy, or enforcement of hand hygiene in Italy, would result in 1,000 hospital days avoided per 100,000 persons each year. The same intervention in the Netherlands would lead to approximately 60 hospital days avoided over 100,000 persons. So it's very context specific. However, the results show that health systems with lower levels of AMR and HAIs can also draw substantial economic benefits. So even Norway, we found that when implementing healthcare-based interventions could result into cost saving for the healthcare system. Now, if you consider that in relation to the health burden of AMR and HAIs compared to other infectious diseases across the EU, just to remind everyone that at least what was estimated by ECDC is that the burden of AMR is is similar to the cumulative burden of influenza, TB, and HIV. And if you look at HAIs more specifically, it's even larger. The burden is extremely high. It's the double, at least in the European countries, of all the other infectious diseases under surveillance at ECDC. So this is just to put a little bit more into context. So what we know is that HAIs carry a substantial cost. That cost effectiveness, that the investments are largely offset by the savings that are generated, particularly in the interventions that target IPC, and that these results are tested in high-resource countries. So we don't have much information in low and middle-income countries, but we would expect an even larger economic and health gain in low-resource settings. Or would it? Would we expect that? So that's the big question that we are trying to ask ourselves. So as I said, we started with a systematic review of the literature, and our goal is to develop a robust methodological approach to estimate the cost effectiveness. So, yeah, and so to do that, we have 4 big columns that we're working on. What are the IPC interventions? And here comes the minimum requirements that we will test. What is the implementation status of IPC in the countries that we're looking at? What is the burden of HAIs in the countries that we look at, and what is the cost of IPC and economic impact of HAIs? So we have to keep in mind about the context-specific issues. We will be using machine learning modeling. We will have to think about how to work out the attributable burden, direct or only, or also include indirect costs. And after some talks yesterday that I had the chance to look at, I want to also try to include some de-implementation and waste kind of interventions, and not only what kind of intervention to put in. This is generally how our project is based. So we start with a methodology. We will pilot some of the through machine learning and observed data in some pilot countries in order to generate estimates, and then hopefully we will be able to create a tool that can be used for advocacy at local level. So the conclusions are to produce estimates in some countries, but also to empower countries and facilities to do their own estimations. So thank you very much, and I just want to remind everyone about the IPC assessment framework survey that is ongoing. You have until the mid-November if you want to participate in the big call for this survey. It generates very interesting data for your own facility where you can identify the areas of improvement. So thank you very much.